Good evening, everybody. Good evening. Hi there. Quite a few of you joining us. That's really very nice of you guys, considering it's so sunny and warm out there, and it's not been like that for a couple of weeks. So, pleasure to have you all. Today we are going to cover the heel. I'm just trying to get my hand in this glove that's not really working. Okay. So the heel today. We're not going to be able to do it in the kind of positioning that we'd like to with Adrian, because Adrian needs to be able to try and film, because of course the point of today is to help you get your orientation correct. So it won't be a textbook positioning from Adrian, but we have to be careful and keep an eye on him, because we really don't want him putting a disc out, trying to twist himself around. So let's see how we go with that. So first thing we'll do, let's look at the plantar fascia. Yeah, a big common theme amongst podiatrists and other healthcare professionals. And what we're going to show you today is what it should look like, what it can look like when it's problematic, and what kind of pathology you can get there. But most importantly today, it's about probe placement, where to put it, how to optimize your image. So we're going to pause quite a bit and try and go through that in detail. Once we've done the plantar aspect of the heel, we're then going to move up to the posterior aspect, and we're going to look at the tendocalcaneal junction, insertion here. We'll look to see evidence of retrocalcaneal bursa, and we're going to have a good detailed look at the Achilles tendon. We'll probably go all the way up to the calf there and have a look to see what other associated structures we've got. We're going to go nice and steady, because the point of this session is to get you the basic skills you need to be able to confidently scan the heel. So any questions along the way? I think Steve's there for you to field them. Please fire away as you go through. If you bear with us for a moment now, we're just going to turn the lights down and get ourselves ready. So just to remind everybody that we've got a tiny window here. The width of this probe and the length of this probe is a torchlight inside the body here. So the thing to remember, of course, is that the plantar aspect of the heel is quite broad. And what you don't want to get stuck with is just scanning along one plane only. And what I want to really remind people of is you need to scan medially and laterally, bearing in mind there's 5 branches to the plantar fascia that all attach and insert around here, as you know. Okay, so essentially you want to find the nearest bony landmark. So some people like to start on the bottom here, some people like to start at the back. Of course, you all know where the heel bone is. It's more posterior. So we're just going to put our probe here. Okay, so immediately we can see I'm the wrong way around, so we just spin that round. Okay, so right at the top of the screen is skin. Adrian's just using his pointer there. And the next layer down, of course, is the fat pad. So if I take a bit of pressure off here, you can see grey, blackish sort of appearance, lots of little black, dark flecks in there. This is the fat pad. Okay, so anybody with fat pad, incidentally, you can measure this fat pad, and if you're suspicious of fat pad atrophy, you can actually see that. You'll see much more large, black, open cells in there, yeah, and the actual thickness of the fat pad will have diminished. So Adrian will measure out the fat pad for you here. Thanks, Adrian. So that amount is the fat pad. Now underneath this strip going along the screen from medial to lateral is your plantar fascia. Okay, so if you keep your eye on the area where the arrow is, I'm now going to take Adrian's big toe and move it up and down a little bit. And hopefully you can see in the heel and of the fascia some movement here. Yeah, that's the bow of the plantar fascia moving as you dorsiflex the toe. So that's always really cool to see. You know, the thing about ultrasound is it's dynamic. So always move and wiggle and jiggle. It just helps you optimize your image clearly. Now you may not have seen that, but that's a very nice mechanism to see. Okay, so below this and this bright white line is the calcaneus, the heel bone, the plantar aspect of it. Okay, let me just quickly show you on Adrian's camera an anatomical model. So if you look here, medial side of the foot, the heel bone, and our positioning with the probe is about so. If you look from the back, so we're right on the medial aspect. not in the central, not the lateral, right on the medial aspect. Okay, let's go back onto the foot.
Just picking up on a technical point here. If you're struggling to get down to see the plantar fascia, I've got my focus here at the right level. But sometimes, because if you get someone with a big fat pad, the ultrasound has trouble getting through. So you can see them at 17 here. If I just take it down a bit, it just allows a bit more penetration to get through, and sometimes gives you a better image. So just remember to manipulate your image there, because I'm getting a lot clearer now down here. I'm on 8.5 megahertz.
Much clearer. Yeah, absolutely. Good point and tip. There's also a way to alter the grayscale between the layers. So if you wanted to make the skin lighter or brighter, or the fat pad lighter or brighter, to be able to see things a bit clearer, Adrian's going to show you how we can manipulate the image that we have to make it easier to see the area that we're trying to focus on. And that's called your TGC, time gain compensation. You'll probably see a row of 6 or 7 buttons on the side of your ultrasound machine, and that's what helps you to control that level. So you can see the movement on the screen here. I'm just rocking my probe. We call this heel to toeing, and it sometimes just helps to just make sure you're not seeing artifacts or things that shouldn't be there. So we've started medially, and you can just about see the calcaneus come into view there, and we can see the plantar fascia overlying. Then I'm just going to scan the lateral aspect, so you can see I'm seeing more and less of this heel as I'm moving across. Now I'm right on the lateral side, and it's almost disappeared off the screen, so I'm going to come back medially again. We're just starting to see the periphery of the calc. Now I'm going to carry on scanning till I'm in the medial aspect, and that's where you can see this plantar fascia, which we'll follow in a bit more detail in a moment. Yeah, and then we're going to scan back across. So not only do you scan forwards and backwards, but you need to go from medial to lateral to really get a good overview. Everybody does it differently. Ideally here, I'd have Adrian in a prone position, laying face down, with his ankle and leg hanging off the edge of the couch, whereby I will be able easily to dorsiflex and plantarflex his foot, and I'd usually start scanning from the back of the leg all the way down and under the heel, because I'll usually, when I'm asked to do a plantarfascial scan, I'll usually look at the Achilles as well, because it's all kind of part and parcel. That's one component to me, with your Achilles, your soleus, and then your plantarfascial merging together. But as we said, for this demonstration, we're just going to try and do it the easy way we can, get the camera on it. So let's get our probe back on and find where we were. So the other thing to note is you can squash this fat pad right down. So watch as I push in and nearly knock Adrian out. And you can see I'm compressing the fat pad there, but you can see that the plantar fascia won't compress, because of course that's not a compressible structure. So that maintains regularity of its shape, but how much movement we see in the fat pad there is very interesting.
What would you expect the normal fat pad thickness range to be, Abid?
About 7 mil.
Yeah.
Depending on the size, height, and weight and age of a person. Of course, the older they get, the more you'll see open cells. You know, these dark patches I mentioned earlier in the fat pad. So, and also, if you're really trying to get the measure of it, make sure you're not pressing too hard. You need to have very, very light touch, just the pressure of the probe line there, if you're going to take that measurement of the fat pad. Because if you press even very slightly, look how much, you know, I'm putting very little pressure on, and look how we're compressing the whole thing. So you're going to get a slightly odd reading, inaccurate reading there. Okay, let's go back on the heel bone. So can we see?
Just going back to that, if you do measure it, try and get a layer of standoff at the top here, and then you'll know that you're the same pressure for each one that you do.
Is there any advantage of doing left versus right? You know,
just want to compare.
Oh yeah. Because what's normal? We'll cover this shortly in a bit more detail. Okay. What is normal for every individual can be different. Right. On average, we say that this plantar fascia here should measure in a normal person, anything from 2 to 4 millimeters. So if we just freeze frame there, and we're going to put the calipers on this for you, because it is very, very important to use your calipers here, because that is really the way to diagnose a plantar fasciitis. So you can see the measure here, and at the top of the screen there, the D, you can see that measures 3.05 millimeters. So that's very, very normal. That's what we want to see. Anything between 2 and 4 millimeters, depending on the size and weight of the person, that's about normal stuff. Anything over that, and you're heading into the domain of plantar fasciitis. And we'll talk about that a bit more in a few seconds. Let's go back to scanning. So you can see the drop off the edge of the heel bone, and then once we've dropped off there, we can actually see the plantar layers in the sole of the foot. But we won't look at that just this moment. Let's go back onto the heel, and we're onto the medial aspect. There's our plantar fascia again. So what we'll do in this case now is we're just going to follow the plantar fascia. So you can see this strip all the way along. I'll probably need a little bit more contact jelly. I didn't put any in the arch there, so always fine to readjust. Let's put a little bit of more jelly in the middle, because we're going to follow the plantar fascia now all the way to the big toe and its insertion in around the plantar plate. Let's see if we can find it. So plantar fascia. There you go, nice strip of it here. You can see it's heading upwards as it bows upwards. Yeah, so Adrian's staying on the line of the plantar fascia. You can get lost in the deep blue sea here, but actually underneath the plantar fascia here is the muscle layers within the sole and the arch of the foot. So I'm right before the midpoint, and we're still following the plantar fascia here. It's still going. Keep your eye on the arrow. Yeah, so let's follow this a little longer, and then what you should start to see in a moment is the periphery of the plantar aspect of the big toe, and probably a sesamoid will pop up here. Hopefully you're all following this. Let me know if you're not able to see it clearly. And then I'm pretty much underneath. Just need a bit more jelly there, so I'm just going to come off for a second. Okay, now we're underneath the big toe. So can you see the movement there as I'm rocking and rolling? Because of course it's a bit convex, sorry, this area. So to really image it properly, and I'm not pressing on very hard, very light pressure. I'm rocking and rolling, and actually there you can see the plantar plate very nicely. Sesamoid, plantar plate, and fascial insertion is right there. You can see I'm right under the base of the big toe. Just to show you the camera. We've moved from the posterior aspect to the calcaneus. We've gone right through the mid portion of the arch, and we've now ended up at the insertion under the big toe. And again, as I mentioned earlier, it's very nice to look at this stuff dynamically. So if I put that picture in the shot again for you, there's a nice view. And then I'm going to dorsiflex and plantarflex the big toe. And look at all that fantastic, lovely movement of the different layers of tissues. Again, bear in mind, once you get to the big toe, you want to scan across a little bit. We can go from one sesamoid to the other. So there's the lateral, and there's the medial.
That's flexor hallucis there.
Flexor tendon, just overlying it there. Yeah, as Adrian's just demonstrated, you can just simply ask the patient to wiggle the big toe as well. Okay, let's follow that all the way back. So this is very, very good practice for you, because it's a nice, easy structure to find, and it really does help to hone your ultrasound scanning skills. So I've just come off the fascia a little bit there. You can see we're just into the muscle belly. Let's go back to the fascia. So we're back on this strip. And can you see how, as I'm scanning along, because it doesn't always follow an exact straight line, it kind of contours inwards a little bit there. So it's always good practice to just, once you have got your probe on it, to keep moving and altering your probe depth, because it can be really difficult to just stay on it in one plane all the way through. Adrian's just showing us this strip here. If you'd like to just point that out. And now we're going all the way back.
So this is moving on the tendon here.
Can you hear Adrian okay? He's a bit far away from the Stream.
There you go. There's the fascia. There's the fascia.
Just, I can only just hear Adrian in fairness, but
Sorry, Steve.
okay, thank you.
Okay, and you can see me putting pressure through the fascia again, and we're on to the medial aspect again. Okay, so when we scan the heel, we want to look at the three main branches really. So I'll say medial, central, and lateral, although they do a bit more complex than that. So now we want to move, now that we've investigated the medial aspect, because the plantar fasciitis can affect any one or all of the three bands essentially. So you really want to have a look at all of them. So we've looked at the most medial one. Let's scan across to the middle, and now we're on to the central slip. And so we can again take our measurement here to see if it's a plantar fasciopathy or fasciitis or whatever the latest terminology is for it.
Fasciopathy.
Thank you. So you can see there, the central branch here now is thicker than the medial branch. So you see it's 3.50 millimeters, and the previous reading was 3.05. Now it's all down to fraction of millimeters between, you know, pathological and non. So it's very important to check all the three branches, and also to compare and contrast with the other foot, because what's normal for one person isn't always normal for another. So we've had a look at the central branch, and you can see that going up into the arch. Plantar fasciitis, I think you can generally only see here at the calcaneal attachment. We know that you can get injury and damage to the mid portion of the plantar fascia, but I've not really seen a case of one yet. I mean, even you know that you know those guys where you dorsiflex the toes and you rub in the arch a little bit, and it's very creepy to see, and there's a lot of crunchy, knobbly stuff in there, and you think, well, has this guy torn his plantar fascia in the central aspect a little bit? Well, it can be quite hard to see that. But again, you can.
Can you describe how a plantar tear would look?
So yeah, so it'd just be like a hyperechoic defect. So you'll see like you can see the two edges of the fascia here. It'd be just like an eaten out portion of the tear, and be very black, be probably a bit of fluid around here. So basically a hyperechoic defect in this fascia.
Yeah, and so to double check it, you can also just gap the fascia by dorsiflexing the toe, and if you see two ends coming apart, then you know you've got a tear. Sometimes it's very, very subtle, yeah. And it also just does depend on the quality of your ultrasound machine as to whether or not it's going to be an easy one to pick up. But plantar fasciitis is very, very nice to see on ultrasound. I really enjoy scanning plantar fascia because there's no guessing. It's really simple and straightforward, and it's very, very nice to show to a patient. So let's just try and give you an example of what a plantar fasciitis would look like. So would you like to just freeze frame for me there, Adrian? And then, so essentially, I think in cases I've seen, plantar fasciitis starts from about 5 millimeters. On average, I think the ones that tend to see the most, they're about 6-7 millimeters. The worst one I've ever seen measured about 11 to 12 millimeters. That was the absolute worst. So on average, I think I see them from 7 to 10 millimeters. That's when they're really, really painful. You'll probably feel some subcutaneous swelling there anyway. And it'll just be pinpoint tenderness, the typical, you know, AM morning and can't walk on it. I don't know if any of you out there have had plantar fasciitis, but I have. I had an episode for about 6 months, so my life was miserable. It's really horrible. It just throws your whole body off. You can't walk at all. So what you'd see is in this area, essentially where Adrian's got his arrow there, you'd see a big black bubble, essentially. Yeah, a big, thickened, swollen area overlying the calc. It's usually generally exactly where Adrian's little marker is, and slightly anterior to that as well. And the whole thing will just swell up and blow up like a little balloon, and it'll be very, very obvious to see. You won't have this grey colour in there. It'll be pretty much dark or black. Sometimes you see vascularity with it. Sometimes you don't. It's one of those odd things. Sometimes I've seen you know, inflammatory stuff going on in the fat pad.
Yeah, absolutely.
Yeah, you see a lot of. So all you need to do is flick your colour flow onto there. Do you want to just do that for the guys now, Adrian? We'll just give them a rough idea. So we'll go this way. Okay, so can you see how the heels switch positions there? That's just another point to note, because I just twisted my probe round. So now the front end is the back end. So you can see that it's on the left of your screen, the heel bone there. And if I just turn my probe around 180 degrees, now the heel bone's back on the other side. So just be careful to orientate yourself properly.
Usually follow this little marker on the top left here. That's your orientation marker.
And then similarly on the probe, you'll have a little knob there to tell you where that corresponds to on your screen. But if you're in any doubt, all I do is just rock it and roll it, and I know which side of the screen is which. So easy mistake to make. So back to the plantar fascia or fasciitis. So this is a normal version. Abnormal version would be much thicker and much darker, possibly have some vascularity in there. And also, of course, this is absolutely excellent for guided injections. So if you just watch, I'm going to try to anatomically locate the medial calcaneal tubercle. And if you watch how I do this, I'm just going to take my finger, keeping the probe in position, and now you can see exactly where I am. So I was thinking I was on the heel bone, but if you look to see, I'm actually in front of it there. I'll just get the heel bone back in picture. Yeah, so I'm not anywhere near the heel bone. I'll come back a 1/4 inch and just press in there. Sorry, get that picture back. And can you see I'm gone past the plantar fascia now? So look how many, just a few millimeters distance from this place to this place. And if I put my injection here, I've completely missed the point. And if I put it here, I completely missed it. So you'll have a failed poor injection. If I get it just here, that is more or less where that injection needs to go. So it's pretty much just over the anterior edge of the calcaneum where we like to inject them, because that's where they tend to be the most problematic. So it's millimeters to get the injection right or wrong. And also you can do that from a plantar aspect. Some of you like to do it from underneath, some of you like to do it from the side. Either way, with ultrasound, you can see how easy it is for me to guide my injection right to where I need to get it to, if I can give that much detail just with pushing in with my finger. So the success rate with plantar fasciitis injections, I think, in guiding them is great. I touch wood, I haven't had too much difficulty resolving them. One nice, neat injection into the right spot can be ever so useful for these guys. So there's some clinical tips for you. What else was I going to show? Okay.
Transverse section, maybe?
Yeah, of course. Yeah, absolutely. So anytime we do a long axis scan, we also should really do transverse axis. So now we're going to spin it round 180 degrees. So now you're looking at the skin at the top again. We're looking down through the layers. You can see the fat pad, and there's the periphery of the plantar fascia, and then we're on to the calcaneus. So just so you can see them a bit more clearly, we've taken the scan from this longitudinal range where we've been scanning medial and laterally along the heel bone, and now we've spun it round so that we can see a cross section through it. So again, really, if you're looking to rule out tears, you need to do a long section and a cross section to properly assess the entire fascia. Okay, let's go back on in our transverse section, and let's just orientate you anatomically here. Yeah, and you can see much broader section of the heel bone, and again it curves round, and the probe is straight, so you've got to kind of curve it round yourself to just get every corner of the heel bone in view. Yeah. All right, so let's just take a freeze frame there and help you to orientate your eye on this image.
Okay. So the calc with fascia, fat pad, and that's the skin and fat layer up there. So the actual plantar fascia is all this here, so it's quite broad. When you're in transverse section, you don't get to see it. Obviously, when you're in the long section, you just get to see the 1 millimeter slice of that. So when you're in transverse, it gives you an idea of how broad this structure is. And obviously you can look out for osteophytes that may be impinging on the plantar fascia here.
Ah, thank you. That's what I forgot. Heel spurs. That's exactly what I was going to talk about next. Thanks, Adrian.
That's all right.
Are they easy to see, heel spurs, typically?
If you get the probe in the right place, they're massively useful. It's just making sure you and this is why we mention this scanning medial lateral stuff as well, because quite often they'll be right on the medial calcaneal tubercle. So you'll literally see a little hook, a little spur, as you would on an X-ray. They can be very, very nice to pick up, but smaller ones, I think you can miss. Yeah. So if it's a real good size one, beautiful to see, and you can actually see them, kind of digging into the plantar fascial fibers as well sometimes.
Yeah.
And again, most are on the medial tubercle. Sometimes you get them central, so you just got to make sure you scan the whole heel. And yeah, they're very, very nice to treat with ultrasound if you're going to do a diagnostic, guided injection, because you can be ever so accurate. So it'll look like a little peak of bone. This at the moment you can see a nice, even, regular, smooth line here of the calc. Yeah, and anything that gets a little bit with your older patients, you'll probably find that heel bone isn't so regular. It's a bit more erosions in there because obviously years of pounding the ground and doing what they're doing, and often you can even get little calcifications within the plantar fascia. So right in the layer there, you'll see bright white speckles all the way through it. Yeah, not as common. I don't think I see them as common in the fascia as maybe the Achilles. But yeah, you can certainly get them, and spurs are very useful. So how many times I've had somebody referred for a plantar fasciitis, and I scanned it and looked, well, your fascia seems okay, but actually right on the edge here, you have got a heel spur. Yeah, so you can have a completely asymptomatic looking plantar fascia. And again, if you're not careful to scan across the plane of the heel, you can end up missing a spur as well, because they do tend to be right on the edge, right on the medial aspect. And as you can see, I've come round the heel bone here a little bit, and up the medial side to just check through, because I don't think they're very often central. I think they're generally more medial calc tubercle.
Yeah, and usually if you can pinpoint with the patient and say exactly where it hurts, and where you place the probe where it exactly hurts, you'll see probably a little spur.
Yeah.
Or a little nodule.
Yeah. So that's plantar fascia in the heel. So this picture here is pretty much your textbook picture. When you scan it, this is what you should see. You should see some skin there, some fat, a nice picture of the fascia and the heel bone and the attachment over it. Fibromas, brilliant idea. Yes. So fibromas in the sole of the foot, as Adrian's just mentioned, are very, very common. They're generally on the fascia or just below, above. They don't tend to penetrate the layer, and you'll just see a big, bright, thickened.
Yeah, fusiform thickening.
Fusiform thickening is the technical terminology, and they can be all sizes and shapes.
Yeah.
Actually, I did inject one a few weeks back in the hospital, and we're just waiting to see what happens. So again, they're very, very nice to see and to treat with ultrasound, because as you can see there again, I'm just putting a little bit of finger pressure, and I can tell exactly where I am on that piece of part of the fascia. So little lumps and bumps you can see appearing in this thin white strip of fascia. And I'm starting to think that they're mostly traumatic, because the amount that I've seen that have had after they've had an insole that's a bit too hard, or another one that I've found is people who've had an insole that's got a metatarsal dome in it and then a big valgus pad, and it kind of creates a pinch point between the two. I wonder if that's actually so I think they're a bit traumatic, a lot of them. Fibromas, what was the other one? Ganglions, cysts. Yeah. You can see all that sort of stuff. That lumps and bumps is tricky. You've got to be ever so careful, and you need to make sure you're well qualified when you're looking at lumps and bumps and diagnosing and assessing them.
Whilst we're there, can we? Well, not so much whilst you're there, but sorry, I'm just reading the question again. What a plantar plate tear looks like?
So
okay, let me just go to the big toe. I'll let Adrian sees loads of these in his clinic, so I'll let him chat to you about that while I give you a nice picture.
Yeah, so here's the plantar plate. So basically, you'd see it's more of a triangular defect. So a hyperechoic triangular defect in the plantar plate, and then if you you can dynamically assess that, and you'll see it either open up or here we go, open up and give the impression of the tear. And you'll see a little bit of fluid in it, maybe. But yeah, it's a triangular sort of defect in the plate. I mean, all this is the plate. So
should be nice and sort of bright grey.
Yeah.
And anything that's got a little dark patch in there could be a tear. And again, as Adrian said, you can just sort of gap the plantar plate by dorsiflexing the tear. I mean, we're kind of mimicking one there. Can you see that little? That's it. That's exactly what. You know. Can you see how we're kind of mimicking? This is an artifact. It's not true, but can you see that little black dark patch in there? Yeah, that could be what it may look like if you have a plantar tear rupture. Would you always see hypervascularity there, Adrian?
I don't actually.
Quite rare, isn't it?
I always look at it and see if there is, but I very rarely.
I suppose because it's not a particularly vascularized area, so you don't always see the kind of inflammatory stuff with it. But yeah, anything grey is good and normal. Anything that starts to go a bit dark, you need to investigate a little bit further. And of course, again, you can't just investigate in one plane of movement. You're going to have to spin on that and have a look to see if you can. There's your plantar plate there between your sesamoids. Yeah, and you can see the flexor tendon just overlying that. So you've got to scan through it in transverse, and you've got to scan through it, spin on it, and scan through it in longitudinal.
Yeah. So whenever you see pathology or think you see pathology, you always look at it in two planes. And if you see it in two planes, then you can be pretty sure it's there. But you can see things in one plane that looks like a tear, and then when you turn transverse on it, it goes, and it might be just artifact. So if you can confirm it in both planes, then you can be pretty sure that it's there.
Okay. All right. I think we've done a plantar heel there. Just wanted to point out the fibres in the fascia as well. You can kind of see these clearly as I'm just manipulating my probe. You can see nice stripy white fibres going all the way through there. This is just what you want to be able to see, and depending on the sensitivity of your ultrasound, of course, because there is a great difference between machines and the quality of them. Luckily, Celtic SMR have got some of the good ones.
Thank you.
I could look at the heel all day long. Let me stop there because we've got to get to the back of it now. And this is going to get even more fiddly for me and Adrian, trying to film this and scan at the same time, so do bear with. So again, we've got to, when you scan the Achilles and the back of the heel, you're going to have to go medial to lateral. We're going to go all the way around this because the Achilles tendon, as you know, let me get the picture of the model actually. It kind of, it starts off quite slim and slender here, about anything between 4 and 7 millimeters in diameter of the Achilles is quite normal. So of course, it comes down the back of the leg bone, around the back of the ankle bone. It stays quite narrow here, and then before it gets the attachment, it broadens out into like a triangle, and it attaches on both sides and at the back of the heel bone. And then don't forget the fibers, of course. And this is the nice thing on the ultrasound scan this evening. We're going to be able to see the fibers running through the attachment of the Achilles, and then underneath they'll start to turn into the attachments of the plantar fascia as well. So you'll see how that is just one mechanism, and why when we scan the plantar fascia we should probably scan the back of the heel at the same time. Okay, so do you want to, how are we going to do this? Let's get lots of jelly. Okay, so right on the back of the heel bone. So we just find your nearest anatomical point. This is fiddly on the couch, but here we go. Here is, okay, so the heel bone is on the right of your screen, and hopefully right above that you can make out the Achilles tendon fibers. So again, nice stripy white fibers to be seen. The skin is right at the top. Let's just fill up that picture for you. And what we'll do is we'll pause it there and we'll annotate this and take a couple of measurements for you.
Oh, wait a minute. Sorry, just do that again.
So bear in mind, it's a bit tricky, this, guys, today. So there's always that little dip there, isn't there, just behind there, at the top of the heel bone.
Yeah.
You've got to get lots of jelly in that little space here. Otherwise, you'll lose contact and not really be able to see anything. So here's the Achilles measured out there, and you can see on the right of your screen in the yellow writing that is measuring 4 millimeters. So that's pretty good. Bit thin, but that's all right. We'll let him off. And then you can see the back of the heel bone, skin. Can you just point out the skin for us? And then sort of the Kager's fat pad there, essentially, isn't it? In this pocket. So just sitting underneath the Achilles there, where the arrow is going round and round. That's Kager's fat pad region. And look at the detail you can get in there. Here you can see, if we look at the back of the heel bone there and the tendon fibre attachments, can you just see a small line, little black layer between the tendon junction and the heel bone? And this is where you might see a slight trace of fluid in the retrocalcaneal bursa, which is what we'd call that if we were scanning. So you can always see a little element of it, but that's what you want to keep an eye on, because of course you do get quite rip-roaring large bursitis there. Quite common. I've actually got one, and if we've got a few minutes at the end, I had a real horrible one. I've still got some evidence of it, so I might be able to show you that. But essentially, you've got that there, and sometimes you get these bursal thickenings in the Kager's fat pad as well, and sort of fluid.
Yeah. But essentially, this panoramic, you can knit the whole thing together, and it will give you a clear view of the whole. There we go. So
forgive my dodgy scanning there, but it's a bit awkward in this angle. But
you can essentially knit the whole thing together and get a good idea of what it looks like.
The entire length of it, because of
but
course
you have to keep a steady hand. Obviously, you get that.
What's that about? Yeah, it could be 5 to 10, 15 inches of scan. You can get all into one frame.
Yeah. Anyway, it's just a little.
You can rotate. Ah, perfect. Thank you. Okay, so back on here, and so we're looking at. I'll just get the. Okay, back onto the scan. So let's look at this Achilles in a bit more detail. So we've got this in a long axis, and this is a real nice textbook example. You know, lots of nice, bright white stripy fibres in there. If it was areas of tendinosis within the tendon, what you'd see would be sort of dark patches and flecks of black all the way through this. But this is healthy. This is nice and white and bright. You can actually even make out the parotinon on there. So if you're doing your Achilles injection, it's quite nice to be able to see. And actually, if you get your injection into the parotinon, you'll see it just shoot along all the way along the Achilles tendon. Because of course, you don't want to inject into the main body of the tendon if you can help that at all. Interestingly, also another point I wanted to just make about this is soleus and the differences in different people's anatomy and the soleus muscle. So here I am approximately 4 inches up from the heel bone, maybe 2 inches from the bottom of the insertion of the Achilles. And in the bottom of the screen there, you can, well, the bright white line is the tibia, back of the tibia. And above that, you can just actually see striations in the muscle. So this is Adrian's soleus underlying his Achilles tendon. And what I like to just point out to people is sometimes I've had Achilles tendons referred to check for tendonopathies and things. And actually, the Achilles tendon looks completely and entirely normal. And what I can see and find often is that people anatomically can have a very low insertion of soleus, sort of insertion in the middle, and sometimes very, very high up there. And what I sometimes have found is that the Achilles tendon has been absolutely fine, but the soleus itself is quite hypertrophied, quite thickened, and quite sort of knotted up.
So I think this even may be flexor actually.
That's actually flexor, yeah. Bit above that, maybe.
There we go, maybe.
So yours is quite fairly normal anatomically, but some people's attach way down at the bottom pole, don't they? Really, really low in there. So just anatomical variants to be aware of. But yeah, you can see quite nicely here Adrian's flexor going there as well as he wiggles his big toe. From this picture. So let's come back to the base of the heel bone. Oh, actually, you have a little bit of a, just making an artifact, but if you've got heel spurs, this is the place you'll find them. So about where the attachment of the Achilles is, you can also get enthesitis here. Do you want to mention how you diagnose enthesitis in comparison with insertional tendinopathy?
Yeah, so basically you just see like little pull-offs into the tendon, very dark, and you just see little flecks of bony irregularity here, and that would be more. And then if you put the colour Doppler on that, it might have a bit of hyperemia around that. And then that's essentially what I'd call an enthesitis, whereas
enthesopathy.
Enthesopathy, yeah. It's just a combination of all that, really. Bit of tendinopathy, enthesitis, bony irregularity. Just call the whole lot an enthesopathy.
I have to say, you've got a very nice regular heel bone there.
Yeah.
This is quite textbook normal, but this is what you want to see. You want to see what normal should be, and you need to fully appreciate and understand that before you start to look at pathological cases. But again, you can get knobbles and bobbles. I often say it looks like Twin Peaks. You know, you can get significant calcifications at the back of the heel and heel spurs. And again, sometimes on the medial aspect, sometimes centrally, and sometimes laterally. So do be sure to scan medial to lateral around the back of the heel as well. So, tendon tears. Now, of course, you can get a tendon tear longitudinal. You can get a tendon tear in the other direction, and you can get a tendon tear intrasubstance within the main body of the tendon. So we'll discuss that for a couple of minutes right now. So to look at that, really, we've looked at. Sorry, Adrian, can I twist a little bit more for me? Thank you. So of course, if you've got a linear tear, longitudinal tear, you'll see it in this plane, but you won't just rely on that. Again, we're going to have to talk about spinning your probe. So once you've got your Achilles tendon in the center of your screen, flip your probe 180. And I'm trying to carefully keep my probe on. There you go, there's a bit of picture. So can you see, you're just getting a window. Look how much contact I've lost. Can you see on either side of the screen here? We haven't got much there. You're just seeing jelly, really. And the only thing you can see here is the footprint of the probe on the Achilles tendon itself. So perhaps a hockey stick probe, you may have seen the smaller ones, could be more useful here, because I'm just losing, almost a half of the picture. Because I just can't maintain contact with a linear probe on something that's slightly cylindrical. But this is the view for checking intrasubstance damage and injuries and ruling out any other tears. So again, let's start at the base of the heel. Okay, so here's your calf, and you should just start to see Achilles here popping into view. So you can see it's quite broad and flat now, and it's spread out across the whole back of the heel bone. And as I move up another centimetre, you can see the fibres come into view. Trying to keep it centrally in the screen, and if you just move up slightly more, you can start to see the shape of the Achilles tendon becoming more oblong and more round. You can see very nicely the internal fibrillar structure, lots of white fibres and speckles, slight septum there in the middle. And then if we carry on going up, can you see it's narrowing and getting more rounded the higher up we go. And now we're about just past mid portion, and now we're going to keep scanning. And can you see how the Achilles here has got much thinner and it's getting quite broad again? Yeah, so let's just go back a little bit. So here is at the sort of lower third of the Achilles, the typical place where we tend to have injuries. Now it's quite round and cylindrical there. And as we head up towards the insertion attachment of the gastroc, it starts to flatten out and broaden out and get wider and wider and flatter.
This is soleus.
And that is your soleus muscle Adrian's just pointing out in the view, just sitting underneath there. So let's see where we can start to see soleus from. So I can't see any soleus there, I can only see Achilles. Excuse me. I'm going to keep scanning upwards till we see the muscle belly starting to pop in view, and you can just see the shape of the Achilles looks slightly distorted there, but that's because of the soleus dropping into view. And we just keep that in the middle of the screen. As I'm moving up the leg, you're getting more picture in the screen because I'm able to increase the contact, even though this is a very awkward position to be scanning in. And we're going to go all the way up to, if possible, if I can get it up as far. Now, can you see the separation? Do you want to just point out the Achilles there for these guys? Well, I'll just try and keep you in view.
Just all that thin bit there.
Thank you. So you can see how thin it is now. And I can actually see very little of it. And I'll come back down because normally I'd go right to the back of the calf, but Adrian's going to fall off the couch. And so I'll come back down again, show you that nice fibrillar pattern and structure. And really, that's your textbook image. So when you're scanning at home there, that's what you want to see in cross-section. And it doesn't really matter if you've lost signal on either side of it, as long as you've got that tendon right in the middle. You can end up slipping off it one way this way, you end up slipping off the other way. Just try and keep it bang in the middle of your screen and try to follow it to its attachment to the calc, and it just disappears off there. I'm just going to quickly move back into long axis because I just want to follow the Achilles tendon fibers until they meet and become the plantar fascia as well. Okay, so let's go. You've got your Achilles tendon fibers right at the back of the heel bone, and now I'm just going to go underneath and start to pick up the fibers of the plantar fascia. A little bit awkward, and just making sure you've got full contact, and there you can see the plantar fascia coming into view now as well. Yeah, so we're right on the bottom of the heel. I'll get my hand out of the way of your screen, so I can go back on that. I can follow it round. You know, you've got to be angling your probe at the same time. So look how careful I am to make sure I'm not losing too much contact on the picture, and then full contact here. And now you'll just start to see the Achilles tendon come into view again. And that's how the fibers would appear. Now, on different people, you can see them less or more clear, depending on the size and structure of them. But it's always nice to be able to show them how that works.
I've got one quick question, mind you, before we go on to the couple of questions I'd like us to cover. What does a Gastroctare look like? A Gastroctare look like, I should say.
So usually I usually pick up Gastroctares mainly at the medial head.
Medial head, yes.
Tennis leg, they usually call it, don't they? And then if you just let's have a look. Come down here. So this is where Achilles. I can't use the arrow at the moment, but just try and get the arrow there. So this is the aponeurosis here. There's the medial head of the gastroc, and that's where you get a little tear on the gastroc there.
And the soleus?
Now, soleus, I wouldn't tend to try and use ultrasound for soleus tears because it's not the best modality for soleus tears. MRI is usually better. I mean, if you do see one, fair enough, see it, but I wouldn't. I'd be careful with the soleus tears. There was a paper about it on trying to pick up soleus tears because they're quite problematic with ultrasound. But
yeah,
if you do see it, good. But if I wouldn't worry too much about it.
Yeah, and I suppose it's a bit of a process of elimination. So if you've checked all the anatomical structures around it and they look quite normal, then you could put down that you suspect that there possibly is a tear, because again, you can find the soleus muscle and prod around it and palpate it, and you can see in real time if it's kind of painful in that area, because it can be quite difficult. As you can see on the screen now, there's quite a bit of darkness coming through in that muscle. So to separate the darker areas of muscle from actual tears can be quite tricky.
The key to picking up muscle tears is to look at these. I'm just trying to get see that septum in there. Just have a look for thickenings and widenings of these septums, because they'll tend to get the tail tend to follow these lines. So, but be particularly careful with soleus tears.
Okay, brilliant, thank you. So I thought this was an interesting question from Chris a lot earlier, so thanks for your patience, Chris. In asymptomatic sports people, How many of these during a competitive year would you expect to become symptomatic? I.e., can this be a pre-season screening tool?
So, sorry, can you say it from the beginning again, Steve? Didn't quite.
Yeah, sorry. In asymptomatic fascia thickening in sports people, how many
Okay.
of these during a competitive year would you expect to become symptomatic? I.e., can this be a pre-season screening tool?
Yeah, I think so. Absolutely. Yeah, and it depends on the sport and the activity and the height and the weight. As we say, the average measurement is somewhere between 2 and 5 millimeters, but I've seen 7 millimeters, which would be really symptomatic in another person, being completely asymptomatic in another one. So there's always anatomical variants that you have to consider as well. But yeah, I'm sure you could pre-screen everyone's Achilles and fascias and record and save those images and probably come back and compare and contrast them, months or whatever time in between you decide to have.
Yeah.
So it can be quite useful.
I feel
Also, as well, we just did the 1 foot today, but normally if I was scanning the Achilles and the fascia, I'd be comparing it with the other side as well, just to make sure we know exactly what's normal for Adrian.
You usually find, actually, or I certainly do, when they come in for, say, a right plantar fascia, because they've waited quite a while for the scan, and they've been basically putting all the weight on the other side, they'll come in and say, well, the other one hurts just as much now, and that's because I've been weight bearing on the other side. So you can usually have a good contrast and compare and contrast with that.
Yeah, so it's a brilliant structure, part of the body anatomically to get really used to and really hone your scanning skills, because you can get quite a lot of detail. There's not a lot of structures there. You've got 2 or 3 major structures, and if you just get real good at scanning them, the amount of value and benefit you'll have just from that, it'll be quite incredible. How many do we all see? Heel pain, tons of it, and sometimes it's from the back, sometimes it's from the bottom, sometimes it's all going on at the same time. We do see people with an Achilles tendonopathy and calcific changes and a heel spur and a plantar fasciitis all at the same time sometimes. So, yeah, very interested in the world of scanning. Completely changed my world and opened it up from the point of doing a MSK podiatry, the traditional sort of way. From the point when we got into imaging, it's a completely different kettle of fish, and to be able to visualize and see these structures and not just think about the way they should appear in a textbook is and you can see how much detail we can get. Look how much we've been able to see and pick up today. So highly useful.
Thank you.
Sorry, walking on.
Not at all. No, you're great. Thank you. A couple of questions around the steroids, the injections that you touched on earlier. So here we go. So read the steroids. What's your thoughts about a weight-bearing structure weakening the area?
Yeah, you got to be careful. I mean, if you're talking about the mid portion of the fascia, anything where you're going to stick steroid into a structure, you've got to be careful. Yeah, but I've been popping steroids into plantar fasciitis for probably a decade, and in that whole time I've seen 2 ruptures, and the question was, were they going to rupture anyway because they're so weak? And we've actually had one, didn't we? You had one 2 weeks. Adrian actually had one 2 weeks ago, and I'll let him talk about this, but that was a complete rupture of the fascia. Absolute nothing left. It completely detached. Do you want to elaborate on it a little bit?
Well, I mean, it was pretty barn door, so I was thinking it was just all thickened and dark, but when I got to it, there's actually no fascia there. I was pressing it, and you couldn't see the fascia at all. It was just completely black. But funny enough, he wasn't that symptomatic. He was in a little bit of pain, but he wasn't any more than that. So it was quite interesting to see. Actually, with a complete rupture, he wasn't actually that symptomatic.
Yeah, and I think he ended up getting referred to orthopedics to see if they could do anything with it, and they told him to bugger off and have some deep tissue friction massage, I think. And then he just went around the house. He couldn't tolerate insoles or orthotics either. You haven't got that protective fascia layer covering all the muscles in there, so probably not too surprised. But yeah, interesting. They can go completely, and I think that wasn't just a medial tubercle branch, was it? It was the complete. All branches had completely popped off.
Yeah.
But was it traumatic or? Do you know how he did it?
You know what? I can't remember now. I think
Very interesting.
I think it was.
I had it and injected it, so well, I'm all right. It was one of But yeah, they're out there and they can happen. I very rarely put an injection of steroid into a mid-portion fascia anyway. Yeah, that's quite rare. Often I'll find it's actually an insertional tendonopathy, you know, either your flexor or your posterior tibial tendon. I had one today. I did take some pictures of it. I don't know if you can put it up on the screen, but this guy had the insertion and attachment of his posterior tibial tendon was nearly 9 millimeters. Really heterogeneous, really expanded, very, very painful for him. He's had it for 8 months. He's an Ironman runner, and he's been treated for plantar fasciitis this whole time, various physios, and then somebody came up with the idea that it was probably a adductor hallucis strain for 7 months. I don't know how they thought that was the case, but no, it was a rip-roaring tendinopathy.
Brilliant, thank you. Changing tact completely here. Any comments on the other optimal settings for the scan other than the frequency? Any?
Depth is important.
Yeah, obviously the focal zone will help an awful lot. It's probably the one thing that gets missed because it's such a small thing on the right hand side here. But you see that little red arrow, move that to the area that you're looking at, and that will change as you scan. So just keep altering that, and you can see on the actual scan that it changes a little bit. I'll turn that up a little bit. Yeah. Maybe you'll see a little bit of change, a bit more, and then that really helps you with the scanning. But the frequency is the main thing because you need to get the penetration through the fat pad.
Gain can be useful as well because I think in different people, you know, different levels of gain bring out different structures as well. So again, it just depends on the individual. You have to tailor your settings to that person and the structures that you're looking for. Yeah. So you know, you'll always be tweaking your knobs.
So you mentioned hockey stick in scanning earlier. Do you find the hockey stick, when you're looking around the structures of the foot, is that where the hockey stick's most used, or?
Yeah, I think so. I mean, especially for these small digits and the smaller nooks and crannies. I mean, Adrian's foot is fairly straightforward today, but as you know, you get some real cavoid, funny, unusual shapes, lots of angles and lumps and bumps in and around. So a hockey stick with a smaller footprint. I mean, probably the size of the tip of my thumb, and you can move in and out on all these little nooks and crannies and corners much more easily. But then again, it's nice to have the slightly larger footprint because you can just get more picture in there and I think maybe orientate yourself a bit better. So I haven't personally, although hockey stick's been around a long time, I haven't used it that much myself. I've always managed to get through with the linear probe, with the small footprint one, and that's done the job for me.